this microphone in a reasonable place? Very good. Well, I'd like to thank Victor for inviting me to do the ghastly talk. I've put a famous British thesp on the screen, and you all know the speech that he's making. Alas, poor Yorick, I knew him well, Horatio. So, wait a minute, what's going on here? Go away. When Victor asked me, I felt that I was being put in the position of one of these chaps. The end of the world is now. Doom, gloom, misery, and I'm here to make you all cry. Thanks, Victor. But really, it's a very important topic. Some of you may recognize this gentleman. There are any Italians here. I hope they do. I've generally discovered that medical students have no idea who Dante is. But there you go. And there he is holding his book, The Inferno. And at the opening of that book, there's a scene where Dante is taken by Virgil down into hell. And it says above the gates of hell, but you can't quite make it out there. So, just here it says, Lasciate ogni speranza, voi che entrate. All hope abandon, ye who enter here. And that's the attitude that a lot of doctors have and a lot of people have towards the idea of making some plans for the end of our lives. But we're all going to have an end to our lives. And trust me, if you make some plans, things will generally go better. That's been my experience. Now, another version of making end-of-life care plans, of course, is the jokey version from Monty Python. And some of you who've seen The Meaning of Life will remember the Grim Reaper. Here he is. And just to let you know that this very tree at which they filmed it is only about 20 miles from the hospital where I spent most of my life working in North Yorkshire. And we also often used to see these boys out and about filming around our way. So I claim a little tiny connection. Now the truth about these conditions, motor neuron disease, multisystem atrophy, progressive supranuclear palsy, all the rest of them, is that while they're incurable, they are not untreatable. And that's the most important thing that we try to get over to our patients at Bethlehem, and that I want you guys to remember today. And just an example of this, this is the team at Bethlehem at this chap's book launch. And those of you who've got sharp eyes will see that his hands are completely useless to him, but he still managed to write an autobiography in recipes, because he was a, as the papers like to say, top chef. He wrote an autobiography in recipes, which some baldy guy is holding behind his head, and we all went to the book launch. The book made a lot of money for a children's charity, and we hope it's going to go into a second edition, and then this time it's going to make even more money for Bethlehem Motor Neuron Disease Clinic, but we'll see. Now, I put together a talk which, or at least some guidelines for a talk, notes about things which I think you ought to know. But I'd much rather tell you things that you want to know. So if there are things that you think are important, or you've got questions that you want to ask me, or I stir you with something I put up here or say, just wave your hand at me and we'll have a nice chat about it, because we're an intimate and small-sized group. So instead of having a lecture, we'll have a seminar. And in proper modern educational parlance, this will be student-centered and student-directed. Okay, so use me as a resource, not just somebody who's going to blather at you. Are you getting a big echo? Because I'm getting a terrible echo. Shall I try and move this down a bit? Maybe. If I hold it, will that be a bit better? Is that? Yeah, that's better. I've nowhere to go. I don't want to ruin a good group. I'll just have to hold it and be very careful. Now, no, I'll hold this one. A lot of people forget what the primary goal of medicine is. And this is something that medical students get taught at the beginning, and then everybody seems to forget. We're trying to benefit our patients, and we're trying to restore their health and their well-functioning, and sometimes that's perfectly easy. You break your leg, somebody puts some screws into it, the bone heals up, and off you go as if nothing had ever happened. We also try to maintain people's health and well-functioning. So somebody gets kidney failure from diabetes, and they go on to dialysis, and that substitutes for their failing kidneys, and they lead a near normal life, apart from having to spend 5 or 6 hours every third day or every other day attached to a machine. And while we're doing that, while we're trying to maintain health and functioning, we're also trying to minimize harm and suffering. And that's the important one that we've got to look at here today. How do we minimize harm and suffering while trying to maintain health and functioning, because we can't really restore it yet. But I'm hopeful that before I kick the bucket, that we will have some useful treatments that will prevent the progression of things like PSP and so on. We've already got one that works a little bit in motor neuron disease, and there's another one under trial at the moment, and another trial about to start. And the same, more or less, applies to Parkinson's disease. And I'm hopeful, because I've got a terrible family history, that we'll soon see something for Alzheimer's disease. But remember, we're trying to maintain function while minimizing harm and suffering. And there will come a point when you can no longer maintain suffering, and all your effort must be put into minimizing suffering. And this is a very nice law in France. So it's in their national legal code, and it's a definition of palliative care, which I think is the best I've ever seen. To alleviate pain, assuage psychological suffering, safeguard the dignity of the patient, and support those who are close to the patient. So that's the task we're thinking about now. Now, we take an approach at Bethlehem, which has been labelled by the Royal College of Physicians in England as neuropalliative rehabilitation. So I'd like to just get you to think about this for a bit. You'll see that ever present is the word death. We will all die. Now, you get an illness and you have acute care, and for some neurological diseases, they are very slowly progressive, and so you can have lots of rehabilitation efforts, and then you can have some neuropalliative rehabilitation, and then you have palliative care and terminal care. Some conditions go fast, like motor neuron disease. Some conditions go very, very, very slowly, like Parkinson's disease, and some are kind of in the middle, like Alzheimer's or PSP or whatever. So it's a way of thinking about how we're going about our task. For some illnesses, there's a lot more disease-modifying treatment, like multiple sclerosis, for instance, lots of disease-modifying treatment. But eventually, everybody, whatever their disease, if they don't have a sudden acute death, will end up having some kind of palliation and some kind of terminal care. And the important thing is for that to be as good as it can be, and as good as the other stuff they've had. And this is just to show you how another way we think about it. We think about symptom control in the middle, and we have rehabilitation type techniques. You'll hear more about those later. We have diagnosis and investigation, disease-modifying treatment, and we have palliative care, and these things all intersect. So depending on what's the matter with the patient, depending on what the problem is, there's different mixtures of these things applying to each different patient. So we take a problem-solving approach, and we have a multidisciplinary team. That can be with hospital-based or community-based, or quite often both together. And just to give you an example, there's the patient, there's the GP team, there's our clinic team. Now, this is what we've got for our motor neuron disease clinic. So we have all these different groups of people available to help the patient depending on the problem. One of the important ones for people with motor neuron disease is the Victorian Respiratory Support Service. because they benefit from having ventilation. But this, leave them out, the respiratory physician, the RSS team, and this is exactly the same sort of team we need for PSP, Parkinson's disease, or whatever it might be. And you'll see that we've got psychology, psychiatry, social work, speech pathology, physio, OT, and so on. And we're looking at a person's physical problems, and we're looking at a person's psychological problems, and doing what we can to help. Now, patients with progressive neurological diseases have some special needs over and above the kinds of palliative care needs that, say, someone with renal failure or heart failure might need. There are often communication problems, and this needs a special approach, maybe some equipment, some special training, and so on and so on. There are lots of emotional problems which may be made worse by the brain disease. It's not just a matter of being sad because something bad is happening to you. With heart failure, get sad because something bad is happening. But in our sorts of conditions, there are also changes in the parts of the brain that look after the regulation of emotion and the expression of emotion, which makes life difficult for the patient and for those around them. There are problems with mobility and handling the person, so equipment, drugs, surgery sometimes. There are often problems with elimination, bowels, bladder, and all the rest of it. There are problems with pain, skin, muscle, joints, bones, and of course, what you might call psychogenic pain, as well as neurogenic pain. People with damage to the brain, spinal cord nerves, they get pains arising from the damage to the nervous system, as well as suffering pain which is arising in other structures. And these all need different approaches. But the important thing is to analyze the problem as best you can, and then set about trying to do your best to relieve it. And I say do your best because some things just can't be relieved. Now, you've heard a bit from Professor Williams about what the neurologist does. I like to put this one in just as I make myself feel better. What does the neurologist do? Well, the most important thing that neurologists do is get the diagnosis right. And sometimes that's bloody difficult. In fact, sometimes it'll take you a year or two to get the diagnosis right. Sometimes you won't get it right until after the person has died and you've got their brain down the microscope. So don't be disappointed if we sometimes get it wrong or sometimes can't give a definite answer. We also should be involved in breaking bad news as well as we possibly can. Some people make an effort, and I've observed that some people don't. We prescribe drugs which may be disease modifying or for symptoms. And we're the only ones that can do that bit. We're the only ones that are allowed to sign the prescriptions. That's our special privilege. Medical Act, 7 years training, we get to sign prescriptions. Lots of other people can do all this other stuff, and many of them do it far better than us. But that's our special little bit. We also work with our allied health professionals and colleagues. We lobby and advocate for people. We do research, and we support people. And I think that neurologists should be discussing end-of-life preferences, and I know that some of my colleagues do, and I know that a lot of my colleagues don't. But that's another matter. And of course, if you want support, there are other people who are getting it. You've now, Australia now has a PSP support group. Didn't used to when I first came here. Motor Neuron Disease Association, Huntington's disease, Parkinson's Victoria, the Alzheimer's Society, the MS Society, there's lots of us. One of the things that we do need in Australia, however, is an overarching neurological alliance, like we set up in the UK, where all these different groups get together and punch the politicians harder than any individual group can punch them. We need a neurological alliance for Australia. Now, how do we go about all this planning for the future stuff? Well, we try and establish a bit of a relationship with our patients. We find out what they already know. We find out what they want to know by asking them. Some people want to know a lot, some people don't want to know anything. That's a bit of a mistake, actually. We encourage them to ask us questions, to discuss things. We encourage them. In fact, I usually find it's one of the best ways into this sort of discussion is just to toss out the fact that well, have you made a will and done a power of attorney? Everybody should have done it. Hands up, everybody here who's done their power of attorney. Oh, this is a terrific audience. Yes, yes, yes. Right on. So that's one of the things that you can sort of spit out and get yourself into this kind of conversation. It takes time, so you have to give people time to do it. You have to check that they've understood. Remember, I was mentioning earlier about when people have brain disease, they have problems with emotional regulation. They also have problems with thinking and with remembering. And so checking understanding is very, very important. And we try to keep the conversation going. If somebody doesn't want to talk about it, we try to keep encouraging them to talk about it and try to wheedle it along. And we judiciously introduce topics like respite care, and maybe the palliative care team ought to come and see you, and so on and so on. So there's a lot of talking and wheedling and encouragement and persuading and answering questions and so on and so on. Now, when we're choosing interventions like disease-modifying treatment or equipment for handling or things to help feeding or communication and whatnot, we need to follow simple guidelines for how to proceed, classical and so on and so forth. And the burden of that procedure, well, if it works, there's no burden. If it doesn't work, there may be a burden. You might have a stroke, and so you'll be paralyzed, and so on and so on. We can talk about all those. It's a bit more intangible when you're talking about the kind of things we're talking about. And we'll come on to what the burdens, which are perhaps more intangible, harder to talk about, harder to think about in a moment. But we think about the risks, we think about the benefits, we think about the burdens. It's a way of clarifying our thinking. Now, what sorts of troubles do people with these sorts of diseases get? And I'm lumping you all together. Motor neuron disease, PSP, so and even the MS patients, stroke patients, we're all in this together. Well, there's problems with rigidity and with incoordination of limbs, with muscle weakness. These lead to problems with mobility, with getting about, with swallowing, with caring for yourself. What can you do about it? Well, you can have equipment, you can have extra pairs of hands to help you, you can modify things, you can have some drugs to reduce stiffness, you can do this, there's lots of stuff. So we have to look at the problem and see what we might be able to do to make it a bit better. So sometimes it might be just a walking frame, sometimes it might be a wheelchair, sometimes it might be a power chair, and so on and so on. People have problems with thinking, so thinking may become slower. You may have heard, it may have been mentioned earlier, frontal limbic syndrome or frontotemporal dementia. That tends to occur in conditions like motor neuron disease, PSP, MSA, and so on, where patients lose empathy, they lose their ability to understand what's happening to them. They may become impulsive and aggressive, and they may become apathetic and unconcerned and not doing anything. This needs explanation, it needs management, it needs care and guidance for the family and the carers and so on. Explanation, time, behavioural strategies. Pseudobulbar affect is very important. This one often goes unhelped when there is marvellous help for it. This is where a person's face will laugh or cry inappropriately or excessively to what they're feeling inside themselves. At least 50% of people with motor neuron disease get it. Most people with PSP and MSA will get it to some extent. People with bilateral strokes get it. People with multiple sclerosis get it. It's very, very common. It causes a lot of distress. It can be helped with simple and straightforward drug treatment. An over-the-counter cough mixture containing the drug dextromethorphan will help pseudobulbar affect. So will some of the modern antidepressant drugs. They have some kind of an effect on this, even without the person being depressed. And of course, there's explanation and teaching the people who are working with the patient that when they burst out crying, it may not necessarily mean that they're sad or in pain or whatever. You have to ask. You can't believe what their face is telling you. And a very interesting thing I learned not so long ago was that Charles Darwin was the first person to write about this in a publication. He actually wrote about it in a book called The Emotional Expression in Animals and Man. People have trouble with bladder and bowels. You may need protective equipment, you may need catheters, you may need laxatives, and so on and so on. So there's lots of things to be done here. This is not the talk to go into those. If people have difficulty swallowing, they may have aspiration. Stuff will go down the wrong way. Or they can completely asphyxiate if they block their windpipe with a big lump of steak. Now, ordinary people do that when they're at dinner, talking, laughing, having a few drinks. They can block their airway with a big lump of steak and you have to get it out. If people are sensible about what they eat and how they do it, then they're not going to do that sort of thing. And in a study in the UK of the deaths of 80 people with motor neuron disease, not one of them asphyxiated from a swallowing problem, not one. This problem with swallowing, with aspiration, asphyxiation, so on, is not completely fixed by having a gastrostomy feeding tube. Just because you're putting stuff down directly into the stomach doesn't mean that you don't regurgitate and then it go down the wrong way, or that secretions go down the wrong way. So it's wrong of people to put it out there, and it's wrong for people to think that having a gastrostomy feeding tube is the sure way to avoid all swallowing problems. It isn't. I'll have more to say about that in a minute. The risk of poor swallowing if you can't swallow is that you may get dehydrated, and if you don't drink anything, you will die within a few days. If you don't eat anything, it will take you many weeks to die. The IRA hunger strikers who were active in Belfast when I was a junior doctor there, each took over 60 days to die by refusing food, because they didn't refuse fluids. So starvation is not the problem. The problem is aspiration pneumonia, and dehydration if people have difficulty swallowing. Now, what's the evidence that gastrostomy feeding tubes do people any good? What are the benefits? Well, the food trial, which was published in the Lancet in 2005, in which I took part, was a trial involving stroke patients. And the conclusion of that trial was that the stroke patients who got gastrostomy feeding tubes did worse than the stroke patients who didn't get them. Very interesting. The Royal College of Physicians in London published concise guidance, from which I took the neuropalliative rehabilitation stuff, on long-term neurological conditions, and summarised a lot of the evidence. So that's a place you can go to if you want to look for reports on studies. But generally, the evidence is that gastrostomy feeding tubes are not an unmitigated benefit to people. And I'll come to the reason for that in just a minute. Dr. Gillick in the New England Journal of Medicine summarised all the studies looking at feeding tubes in people with advanced dementia, and showed that it was actually harmful and created terrible burdens for the people. And we'll come back to that in a minute. There's been a clinical review of peg feeding done in the BMJ, and we've had some experience at Bethlehem, and I've had some previous experience in the UK using peg tubes. So let me just get it. So the benefit of having a peg tube is that you certainly can get nutrition and fluids into people. You can give them drugs easily. However, it doesn't always improve nutrition, because whatever the disease is, it continues. So our patients with motor neuron disease will continue to waste away. So will patients with cancer. We have a peg tube in because of esophageal blockage. They've got secondaries in their liver in other cases. They will continue to waste away. So the peg tube doesn't always guarantee improved nutrition. If you get a peg tube in, you certainly can live longer. Now that's where the burden comes in. If you're pretty fit with motor neuron disease and can hardly swallow at all, then a peg tube will make you live longer while you can still get about and do things. If you've got Alzheimer's disease and you're so helpless that you can't swallow and someone puts a peg tube in, you will lie in bed completely locked in and helpless and live on and on. And I'm sad to say that exactly the same thing applies to people with progressive supranuclear palsy, and I've seen it. People who live on for a couple of years, bedridden in a completely locked-in state, with us having no idea what's going on in their heads or where they're suffering or what. For some patients with multisystem atrophy, the same can apply. For some, Not necessarily. So this has to be weighed up on a person-by-person basis, what the benefit might be and what the burden might be. So having a feeding tube is not the immediate, quick answer to all swallowing difficulties. It's something that needs to be thought about very carefully. So we mentioned about the burden. Becoming more helpless, mentally and physically, locked in, possibly suffering more. I think it must be a great suffering to be locked in and helpless, with no way of communicating, no way of doing anything. And of course that may make your nearest and dearest suffer more as well as they watch you and try to look after you. So there's a burden there which has to be thought about. What else can we do about swallowing difficulties? Well, you're going to hear about that shortly. There's lots of things you can do. An interdisciplinary assessment which is thorough. You can modify food and fluids. You can get the person in the best position. You can use the best equipment for feeding. You can learn safe swallowing techniques. You can manage secretions. You can train the people who are doing the feeding. There's lots and lots of things to do. And there's just a little example. There's some feeding equipment on one side and some modified fluids on the other. And some of you may already be familiar with some of these. We give people clear instructions. We write out instructions with photographs of positioning and whatnot, and then laminate them, and they go with the person to wherever they're going to stay, whether it's home or nursing home or whatever. Correct positioning is very important to make sure people can feed safely. Now, why do we want to think about an end-of-life care plan? Well, if you don't, or if you make the wrong end-of-life care plan, then bad things can happen. And I always use this little slide from the BBC, February 2005. Here's an elderly man in the terminal stage of Parkinson's disease. He is certainly, and we know for sure, demented. He is physically helpless. No, we know he was at the end. We know he was. He may not have been at the beginning, but he was at the end. And he was also completely physically helpless and no longer responsive to Parkinsonian drug treatment. But 3 times he went into intensive care, was intubated and ventilated, and then returned to his home in the Vatican. Now, I'm not sure that people who were looking after this poor old man were doing him a service by doing that. And I certainly have it specified in my power of attorney that nobody's going to do that to me. Victor knows, my daughter knows, nobody's going to do it to me. But that's what happens to you if you don't make an end-of-life care plan and you make the wrong one. He could have ended up on ventilation, because he's rich enough, of course, to have all that kind of care. He could have ended up on ventilation and ground on, bedridden, ventilated, tube-fed and whatnot for ages. And if you want to see somebody who's like that, do any of you remember Ariel Sharon, who was once Premier of Israel? Well, he's still alive, ventilated and tube-fed, at the last time I looked him up on the internet, in a hospital in Israel, even though he's in a completely vegetative state as a result of a massive intracerebral hemorrhage, at least 9 years ago, was it? Was it 9 or 10 years ago? I shrug my shoulders. What can you say? Of course, this is the other side of that coin. For those of you who like Gilbert and Sullivan, this is the memorial to W.S. Gilbert on the Embankment in London near the theatre where all their plays, their musicals were published. And you can't really read it properly, so I'll read it out. It says, and it's a poem by Gilbert himself, "Is life a boon? If so, it must befall that death, whene'er he call, must call too soon." Well, of course, in Gilbert's day, there was no PET tubes, there was no ventilation, there was no dialysis, there was no drug treatment for anything except our old friend morphine, aspirin, and digitalis for heart failure. So there was no risk of death, when death called too soon, you being turned into a person who's locked in and helpless and unable to experience or do or maybe suffer. He didn't have that problem. But that's what we're balancing, of course, isn't it? We're balancing benefits against burdens. And for some people, it's a benefit to stay alive another day, to see your child get another day over, or whatever it might be. For other people, it is not a benefit to stay alive. And there comes a point when enough is enough. And that point is different for every one of us. But some of us will have to face it. Some of us may not. We might just get a heart attack in our sleep. So life-sustaining measures are what we have to think about. We can sustain and prolong life, we can supplant or maintain bodily functions with lots of equipment. Ventilation, dialysis, artificial nutrition, hydration. We can also, apparently, bring people back from the dead with attempted cardiopulmonary resuscitation, and we see it on the television all the time. So, Chicago Hope and ER, some fellows in the UK, counted up the number of survivals from cardiopulmonary resuscitation throughout the period of the programs. Any of you seen Chicago Hope or ER? Yes, of course we have. 75% immediate survival and 67% survived to be discharged from hospital. Fantastic! What's the reality in the real world that I work in? 15% immediate survival of an in-hospital cardiopulmonary arrest, 10% survive to hospital discharge, and only half of the survivors, that's 5% of the total, return to their previous level of function. The rest were worse than they had been before the attempted cardiopulmonary resuscitation. Now these are worldwide studies, not just in Australia, not just in the UK, worldwide. So the bald truth is that nobody would take a chance on a treatment that's only going to work about 1 or 2% of the time. And I certainly don't want anybody to try resuscitating me if I have the misfortune to get motor neuron disease or PSP or whatever. Thank you, no. Because I know it won't work. It will be an attempt, and I do wish Australia would introduce the UK terminology and always call it attempted cardiopulmonary resuscitation. Because most of the time, it's an attempt that fails. And we can predict who's going to survive and who isn't. There's a morbidity score, and I can show you where to get these morbidity scores if you want. And your pre-arrest morbidity will determine whether you live or die from attempted cardiopulmonary resuscitation. And the sort of people who don't do well are people who are older than me, but only just. People who have a chronic disease, whether that be cancer, neurological disease, renal failure, whatever, diabetes, and people who have a severe intercurrent illness, like pneumonia or whatever. So, what else can we do? Well, I said I might be gloomy, but this is what we can do, and this is what we must do, and this is what I truly believe we ought to do. We should be alleviating pain, we should be assuaging psychological suffering, and we should be safeguarding the dignity of the patient and supporting those who are close to the patient. That's what we should be doing. And that's what we try to do at Bethlehem. And this is the way it's done. And I have here Raphael's famous picture of the School of Athens with all the philosophers talking about what should be done. Well, we've got to communicate with each other. That's with the patients, with the families, with the other members of the team. We've got to cooperate with each other. The members of the multidisciplinary team, the community team, the patients, the families, and so on. And we don't want any boundary disputes between different disciplines, and we don't want any demarcation lines. Oh, well, that's your job, I'm not going to do it. But don't you do my job, that's my job, and I'm only the one who can do that. We can't have those kinds of boundaries. Sometimes I have to do something that only a nurse would do, or only an OT might do, or whatever. Because I've been at it long enough to have picked up a few little tidbits about what they do, and they can do little tidbits of what I do. One of my colleagues recently diagnosed her mother's condition correctly before the neurologist did, occupational therapy colleague. So we don't need any demarcation lines. And John Donne sums it up for us. Whether the gates of my prison be opened with an oiled key by a gentle and preparing sickness, or the gate be burnt down by a raging and frantic fever, a gate into heaven I shall have. Thank you. So, I don't wiggle this about too much. We're ready for questions if anybody has them. Somebody was asking a question earlier about neck flexion and multi-system atrophy. I don't know whether they got a satisfactory answer from Prof. Williams, but my answer is it's bloody difficult to manage. Yes. Yeah.
Is there any other questions for Jim?
Switching some.
Jim, this is a very personal one. My husband has PSP, and a couple of years ago we made end-of-life decisions and signed them and everything. How do you cope when you've chosen not to have antibiotics and you got pneumonia last December, and we decided that he does want antibiotics? How do I, as a carer or as a family, cope dealing with that situation? And how do I know if he can't communicate? How do I know when to say no?
You've hit on a really difficult problem with advanced care planning, because they're not etched out in stone and they're not legally binding. They're a guide, and sensible doctors and medical teams will follow the guide and try to come to a sensible decision with the patient and the family. If a person changes their mind, they change their mind, and there's no problem about that. Politicians are allowed to change their mind as well, except, of course, by the...
Inviting me, I think the subjects I'm dealing